Welcome to the Egg Whisperer Show, a podcast exclusively designed to create more reproductive health awareness and discuss your fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
Hi everyone, I'm super excited to have Salu, an awesome embryologist, and he's actually thawed one of the longest frozen embryos in U.S. history. It was thawed for over 19 years.
One of them.
One of them.
Many. I have worked with many embryos, have created many embryos, and
5,000?
5,000 injections, or yeah, it's a lot of embryos created.
That's a lot of eggs and a lot of sperm, Salu.
It sure is. It's wonderful, and
Yeah.
I'm very glad to be here today. Thank you for
Of
the
course,
invite.
of course.
It's very exciting to share my knowledge
Experience.
and information with all of you.
Yeah. So tell me, what made you say one day, because you went to UC Davis, right?
Yes.
And what made you say, I want to be an embryologist?
It was a funny pathway because before I was going to do computer work and I was going to work in doing programming, being a tech in San Francisco. And all of a sudden I got a job on campus and I started working at the health center.
Mm-hmm.
And then one day this nurse told me, it's like, why don't you go and do phlebotomy? It's a good job. You
Yeah.
can do that during the weekend
Yeah.
when you're studying. It's like, oh, wonderful. So I did that, and at the same time I worked on the weekends in a fertility clinic and went to Davis, and eventually I chose a major because it was time, and then
Yeah.
I did biotech, which is
Yeah.
kind of biology with informatics, but I really was intrigued by the fertility world, working as at this fertility clinic.
Yeah.
And then I finished college and I was invited to work at this fertility clinic as an embryologist.
Yeah.
And since then, I just love what I do.
Yeah, so you're like an embryo whisperer. And how many years would it take, like for other people out there who are perhaps interested in a career in embryology, how many years would it take someone, let's say, from graduating high school until when you're actually sitting in a lab and working with eggs and sperm?
So most of us come from the animal world. We do a degree in biology with cell biology, animal biology, or something related to the biology field. And then there's some colleges in California and the US that offers a major in embryology,
Okay.
but mostly in animal because you don't want to be practicing with humans,
Right.
of course. And then you graduate 4 years, and then you do a job on training at the fertility clinic that will take you. And most of the job training takes about 2 years.
Okay.
And then there's some master's programs, which I went to University in Leeds in England. I got a master's in clinical embryology and andrology
Nice.
to more understand what I do and do some research as well. So
And get a whole bunch of degrees.
yeah, pretty
Yeah,
much. And
yeah.
then one degree after the other
Right.
degree, and I never thought I was going to have so many degrees after high school. But
Right.
yeah, that's where I am today.
Yeah, that's exciting stuff. So we're going to talk about the nuts, and I did just say nuts, and bolts of
Yes.
IVF. And I realized we actually look similar, except I have hair.
And I don't. Well, that's how they look. The sperm, they'll all look the same. We don't know if they have hair, if they'll have hair, or if we just don't know. It's
Right.
all the same.
All the same. And so this is a picture of an IVF lab. This is basically
That's
your
where I live.
home
My
every
home
day,
for
all day.
8 to 9 hours a day, and it's clean air. It's no sunlight, but nice light.
Yeah.
So I would say we breathe the cleanest air whatsoever, just like the embryos. It's a very clean environment. So
So people who are interested in anti-aging therapy
maybe that's
should
a
go
could
become
be,
embryologists.
yeah, and no sun exposure.
And so this morning I did an egg retrieval. I retrieved over 10 eggs from somebody. And so I put the egg in test tubes and I hand them to an embryologist like you. And then what do you do from there?
So from there, we dip that into a dish. So test tube babies, yeah, because they come from a tube.
Yeah.
So we dip into a dish, and then we're looking for eggs into that solution, which is that
Right.
liquid.
Right.
And they look like that, this picture
Right.
showing right here.
Right.
And at this point, we don't know if it's mature or not because
Okay.
we cannot assess the maturity because all the cells around, it's beneficial because that attracts the sperm.
And so what are those cells called?
So those are the cumulus cells.
Cumulus cells.
Yes.
Okay. So you have cumulus cells there. You don't know if the egg's mature or not. So what do you do next?
So depending on what treatment your physician chooses, whether if it's going to be IVF
Right.
or ICSI.
Right.
So if they choose ICSI,
right?
we have to strip the eggs.
So there's a lot of stuff that goes on behind the scenes in the IVF lab, people. There's a lot of stripping going on.
A lot of stripping. It's even funny when I say, can you strip these eggs? Well, because we're stripping to assess the maturity of the oocyte, which is egg.
Okay, here we go. Mature or immature? Go.
So that's immature.
Okay.
And that's immature. So you can see the GV, which is the germinal vesicle.
Germinal vesicle.
Which is immature egg. So when they tell you it's an immature egg, most likely it's an M1 or a GV.
Okay. And so sperm and M1s or GVs,
they don't like each other.
They don't like each other. Why? Why don't they like each other? I don't get it.
Because there's too much chromosome involved in that environment. So naturally, human body and nature is amazing to say that's not good because there's too much DNA there, so will not fertilize.
Okay, so GV, M1, not as good.
Even if I tried to put an sperm inside of this egg, most likely the egg will die or become atretic or not fertilized.
Okay, so how about this? What if you get an M1 and it becomes, and we'll talk about M2 in a second, what if it becomes an M2 like 2 to 3 hours later?
Then could be a chance that can fertilize and develop into a normal embryo.
Okay.
But again, there are lower chances to develop into a normal embryo.
And what do we call that? Something like M1 conversion, something like that?
M1 conversion to M2. Okay. So we put a note there that was the polybody extruded. So the polybody is this little guy right there.
Right.
So that's a polybody that got extruded, and that now is a M2.
M2. And M2s make you very happy, right?
Yes, make all the embryologists very happy because that's a egg ready to be fertilized.
Ready to be fertilized.
And that's it's a golden egg. That's a beautiful oocyte.
Yes. And so when you look at an egg, you just said that's a beautiful egg. So what about this egg makes it beautiful?
So you can see that the oocyte, it's not dark or granule. It's a very smooth surface of the oocyte. The PV space is not that large, which is the PV space, that's what I call it, between this space right here, the egg and the zona pellucida.
Right.
And so those are characteristics that we're looking at to determine if it's a good quality oocyte.
Got it. So I'm going to put up some pictures of, I know. So this is an egg
kind of looks
with
like I had on.
vacuoles, right? And so what happens when you see this, and how often do you see eggs that have vacuoles in them?
So we see them once in a while, and those are signs that they're not good. Now, when we inject them, if they're a mature egg, we always inject them with a sperm.
Right.
And if they develop good, if they not, then could be a characteristic of the vacuoles.
Got it. So it doesn't necessarily mean that you'll have bad embryos,
not
but it could be a sign you may not get as many as you expected.
Correct. Because I've seen a patient when 4 or 5 was just like this, and I injected, and I was like, I remember even writing the notes, so like, poor embryo, a poor egg, and the next day, all those vacuoles were gone, and it was normal fertilization. I was like, wow, miracle.
That's awesome.
Right there.
That's awesome. And so if, let's say, you're an egg freezing patient, and you have eggs like this, I know you don't have eggs, but if you did, knowing what you know, would you consider going through more cycles because of this?
Definitely, because that's a sign that you want to record. We as an embryologist, we record that information if we see that it's not a normal looking oocyte. So the physician can recommend another treatment, definitely.
Very good. So then this is another egg physical characteristic that's sometimes seen, and it's like grainy.
Yeah, you can see there's a little grainy a little bit here on the top. So those are characteristics, again, that we record when we see them after stripping those eggs.
Ooh. And so no one wants to have their eggs described as vacuolated, grainy, brown.
It's a good information to provide. It's always to know better the information than not know the information.
Right. And then, I know, sorry. But if there's anything that happens, is there anything like we can do as human beings that could change the quality of the eggs? Or do you think that there's something maybe, this is even a better question, is there something about the lab environment that can cause this?
The lab environment, all the lab environments, I'll say in the Bay Area, in the US, they're pretty good. They're regulated by CAP, and those are good institutions. I would say those labs are great. They provide good services, and sometimes just the quality that is affected.
Right.
It's probably the patient went through some problem in the past, health habits, smoking, anything that neglects your health could affect your oocyte quality.
Right.
Definitely.
So I tell patients to get into the best shape of their lives, consider supplements, acupuncture, anything and everything you can do to improve egg quality, do it. It doesn't necessarily mean that it's going to work, but it can only help. So tell me about what you see in this picture here.
So this is a oocyte or even a blast with all those fragmentations. They're just more than 50% fragmented oocytes. So that's a pretty poor quality oocyte.
Egg.
Yeah, definitely.
Yeah. But if you saw this, would you even try to inject it with sperm, or is it just not a mature enough egg to do that?
The criteria is if you see a polybody and it's not an awful egg, then definitely you want to inject, because you always want to give a chance.
Got it.
There's never never in the lab. There's always a possibility. I believe there's always a chance. I've seen embryos that came from death and they're survived, and it's amazing what we see.
It is amazing. And so what about this egg? How abnormal
egg,
does this
there's
look
a
to you?
little bit fragmented polybody.
Around
it's like you have 2
right there.
or 3 actually right here.
Yeah.
So that is just a fragmented polybody, and that's something that you want to note if you see many of them.
And how does that happen?
So that can happen through the process of when you're stripping them, or also could be that when you got retrieved to the pressure. There's many questions that it's unknown. It could be just that it was made like this.
Got it. So when you see an egg like that, you typically don't see like 10 like that, right?
No, it's just
maybe
one.
there's just one.
Between the cohorts, you see 1 or 2 or none.
And then
it really
would you
depends.
still inject?
You still inject, definitely.
Still
That's
inject.
just a normal M2, just with the polybody that's got fragmented.
Okay. Yes, what's the question?
In a regular IVF cycle without ICSI, is it normal procedure to strip the eggs before allowing the sperm to naturally try to fertilize the egg?
Right, so basically, is it normal to do IVF or ICSI, and how do you choose?
The choice is based on the SRM guidelines, where they recommend IVF unless if you have poor sperm quality. And the best is just ask your doctor, and she or he will be able to determine what's the best treatment for you.
Right. I'm going to ask you this other question now that we're actually segueing into sperm. And the question is, do you actually prefer ICSI if a patient's doing genetic testing? Because there's this
great question that a lot of people has asked, and the best answer that I got from a genetic counselor that spoke directly with the reference lab, it does not matter if you're doing if you're doing PGS, if you do ICSI or IVF.
But technically, what do you prefer? What makes your life easier as an embryologist as far as technically speaking?
There's no preference for myself, because when you're removing the trophectoderm, you don't want to put combined DNA of the sperm with the trophectoderm.
Right.
But by the time that you do the trophectoderm biopsy, the embryo probably already fall off, and you have no problems with contamination.
Got it. So for those of you who don't know what a trophectoderm is, or trophectoderm biopsy, keep watching, because we're going to get to those terms too in a second. Okay. So let's talk about swimmers, and do swimmers really matter? So that was a question that I got emailed. Like, does the sperm integrity, strength, health matter when it comes to
DNA
fertilizing eggs?
Yes, it definitely does, because I have presenced myself a case where we used the same donor.
Okay, so an egg donor. So you have 1 set of eggs. Okay.
And from that cohort, she had 20 eggs.
Okay, 20 eggs.
10 went to sperm A, and 10 went to sperm B.
Okay.
Sperm A was very poor quality. They poor morphology, poor motility, poor count or lower count, or the count pretty low.
Okay.
And overall, that sperm quality was pretty poor.
Okay.
And therefore, the embryo quality from that case was developed very poor and delayed.
Okay. So how many embryos did they end up getting in that batch?
I think it was only 1.
Okay, got it. And so then B.
From the other B was great sperm, super swimming. They were great. They met the 2/5 standard.
What does that mean, 2/5 standard? You're using words that are like,
right, what's happening?
Yeah.
So we use a guideline through WHO, which is the World
WHO. Okay, cool.
Organization. And they set numbers for us to say what's normal and what's not normal, because we need to decide what's normal and what's not normal based on that table.
Got it.
So that sperm, or that patient had met all the standard according to WHO, and those embryos developed into beautiful blastocysts. I think she had 5 or 6 frozen.
Right.
And great case.
And I think that's such a great example that you talk about tonight, because so many of us as women, we just internalize everything and blame ourselves and think that it's us, it's us, it's us.
No, it's not always the woman, nor always the man. It's 50-50.
Yes.
So it's always the guys.
Yeah. So Salu and I can talk about this all day, every day,
And
for
actually
hours
we do,
and
don't
hours
we?
and hours, and we do. I know. So this is super fun for us. So thank you again for being
course.
here. Okay, so now you
That's-
got the egg, and now we have to inject the egg with sperm. So tell me what's going on
So
this
that's
slide.
which I can see right here.
And what does
on
that stand
slide.
for? ICSI.
Intracytoplasmic sperm injection.
Got it. Okay.
So that's when you get a very thin needle right here with another holding needle. Well, crossover. You will then place in one sperm
Okay.
inside of that mature oocyte.
Okay.
One. So
Yeah.
people sometimes ask, it's like, do you put two sperm for two kids, or how they are twins equal? It's like, no. So we put one sperm into one egg.
Right.
If that egg divides and one of the cells hatches out and the other one becomes, so there's a chance that both of those cells from the same egg and the
Right.
same sperm
Right.
becomes twins.
Right.
identical
Very
twins.
rarely, though. I mean, that's super rare.
But that's the case where it's only one and one. So
Right.
that's just pay attention.
Right. I get that question too. I thought I was the only one where people say, can you put two sperm cells in the egg so I can have twins? And I'm like, I don't know where that comes from. But maybe the same people.
Yeah, probably.
It could be.
So here's the holding. So that's
Yeah.
we're holding the egg. We're not harming the egg. It's just
Right.
remember if you have if you think about if you have an egg and you're holding through a holding under a solution, under a drop, under the microscope, in a controlled environment
Right.
where the temperature is always warm at
Nice.
37
Oh, that sounds very
Celsius.
relaxing. Okay.
And it's very relaxing.
Yes.
It can be very relaxing. It's therapeutic sometimes
Right.
because you're just looking at them and it's
Inject.
and listening to music.
Right. So let's say, what's your song of choice, Salu?
Oh, that's good questions because we rotate. We have Pandora in the lab,
Uh-huh.
and depending who arrives, the first person in the morning chooses the music. So
Right. I see.
we have all kinds of music.
Got it. So let's say 20 mature eggs. How long would it take you to inject them?
20 takes about 2 minutes per egg
Okay.
to a minute and a half.
Right.
So you pick the sperm, put inside the egg,
Yeah.
and the sperm selection. Did we talk about that?
Oh, I want to talk about it. Let's talk about
So
it.
the sperm selection is another factor. It's like, how do you choose what's the best sperm?
Right.
Well, the
Right.
best sperm that you want to choose is the one with the best swimming. So you want them to be swimming very quickly. Also, you want them to have a morphology. What's the morphology of nice sperm? You don't have two tails. You want to have only one tail.
Right.
You only want to have one head.
One head.
But sometimes you only see the sample. There's two heads, three tails.
Right. Missing head.
They look like octopus.
Yes.
And it's like
Octopus sperm.
octopus sperm.
Don't want
I've seen
octopus
no,
sperm,
no, no,
people.
Only one.
No, right.
And then you place that
Right.
inside of the egg, and
Okay.
and then the next day you look for fertilization.
And then there's something that a lot of people are doing now called Pixie, and I think of
Pixie.
it as like picking the best sperm for ICSI.
Well,
Tell me,
that's
how
nice
does that work?
terminology.
Yeah.
Pixie.
Pixie? Yeah.
Huh?
Yeah, I know. Clever.
Well, the Pixie method is when you will choose a mature sperm
Okay.
that binds to that plate. Because think about if the sperm has a
And
bind.
is this the plate or is this a droplet here?
So that's the drop in the plate.
Got it.
And they bind. So the tiny little things there, those are the sperm. They
Okay.
bind to that plate
Yeah.
because they have this receptor, the plate and the sperm head, that they are fully mature. So
Right.
we look for fully maturity and also for best morphology when they bind
Got
to
it.
the plate.
And so the ones that have bound tend to be more genetically normal.
Correct.
Got it.
So you'll then select that and then inject into the egg.
So why doesn't everyone do it?
Well, there's the prones. There's a lot of steps that you have to do. It's a special plate.
Yeah.
It takes time. That you have some sperm that necessarily bind to the plate. They're not morphologically normal.
Got it.
So you want to have a nice sample. If you have too few sperm,
Right.
then they will not bind.
So you still need enough sperm to be able to do
correct.
this.
So you have
Got
to
it.
meet a specific criteria to fit into the category of the study that they developed.
Got it. Got it. Okay, so now I want to talk about, you've made the embryo, right? You've injected the sperm into the egg, and then what happens? Like, how do they grow?
So they start dividing.
Yeah.
They divide between 2 cells, as you can see,
Right?
4 cells, 8 cells. They become a morula.
Yeah.
They become a blastocyst.
Right.
So those are the days that we call in the lab. So
Right.
day 2 embryo, most likely you'll be seeing that on day 2.
Right.
Day 4 and day 3 embryo, you see 4 cell to 8 cells.
Right.
And cells, when you say cells, what are cells? Cells are things that you can count inside. Those are blastomeres. You can see 1, 2, 3, 4. And then also we assess for fragmentation.
Yeah, so like how pretty the embryo is.
Correct. So fragmentation, if those blastomere, those cells, start degenerating or tiny, think about Dippin' Dots ice cream.
Oh, I love that ice cream, actually.
I know, but I don't want to see Dippin' Dots ice cream in the lab because they just like those little dots, those are fragmented embryos.
Got it.
So they kind of look, those are nice, grade 1 assessment, fragmentation 1. Symmetry 1 as well. So those are great embryos.
And so the degree of fragmentation and symmetry is related to like the chance that embryo is going to be genetically normal and stick and grow and turn into a healthy pregnancy,
and develop
right?
into an isoblastocyst, correct.
Got
because if they are poor quality on day 3,
right,
they'll most likely arrest as they grow in the lab.
So when you say arrest, does that mean they just stop growing?
They stop growing.
So we use words like arrest, no further cleavage, degenerate. They're just not viable anymore.
They're not viable
and you
anymore.
can actually see it. You can actually tell when you're looking at the cells that they've stopped growing.
Because you see on day 5, for example, and you see day 3 looking, if you see on day 5 and you start seeing this on day 5, those are arrested embryos. They will not further develop into a blastocyst.
And so when we say day 3 and day 5, what that means is 3 days after the egg extraction or the egg retrieval procedure.
So we call the day of the retrieval day 0. Day 1 is the fertilization. Day 2, day 3, day 4, day 5, up to day 7. Sorry,
no, that's okay. It's okay. You can hit me. So chickens, what do chickens have in common with humans?
It's like 2
Is that like
shells in here.
It's like a 2AA embryo right there.
So that's, because you can see a little bit of the ICM.
Yeah.
So what are those shells? Those shells are called the zona pellucida.
Right.
And they hatch out just like a chick did there. Your embryos, I was an embryo. I looked like that. I don't know if I was a 5AA or a 5AB. I think I was 5AA. Both of us. I'm weird for 5AAs.
I was a 6AA on day 5.
Oh, yeah.
That's what my mother tells me.
So she was an advanced embryo.
Very advanced.
So those are embryos that you most likely are looking at day 5, day 6, or day 7. Those are blastocysts. So they're hatching out. So you see the trophectoderm. So trophectoderm is the future placenta, which will attach to the epithelium of the uterus and will become the placenta. And the ICM, which is the right here, a little darker part, which is like a glob of cells. Those are the ICM and the inner cell mass. That's the future fetus, the future baby.
Right, and so that's the first letter score that an embryo gets. So the first number, 1 through 6, refers to how expanded or hatched the embryo is, and then you hear terms like expanded blast, partially expanded blast, fully hatched, all those kinds of things.
So those are hatching blasts. So I would call that a 5 something, 5AA or 5AB.
Right, and then the second letter refers to the trophectoderm quality.
The quality of the trophectoderm. So the trophectoderm, it's how many cells do you see there? Because sometimes we call them C. So sometimes, I had a C embryo that was not frozen. And people's like, why you didn't freeze my embryo?
Right, exactly.
Well, see, I'm answering.
I get that, I know.
It's because most likely those cells would not survive a freezing and thawing process.
And they're not really
and they're not
good
viable
enough quality to turn into a healthy pregnancy.
Correct. Will not attach and cause, if they attach, could cause miscarriage, or there's things that you don't want to happen.
Yeah, so for us, if an embryo had the chance to stick and grow, certainly we would give it that chance, even if it was like a 1% chance. But if the embryo already shows signs that it's not alive or viable, we're not going to freeze it. We would strongly consider against transferring it too. Yeah. Okay, so then another term that people talk about is assisted hatching. When do you do that in the process?
So assisted hatching is recommended based on certain population that can help with implantation. Patient's age, basal FSH, if the embryo or egg was frozen before, because during the freezing process, the zona pellucida, which is the shell, can get hardening, becomes hard, and it does not expand. Because you want that to expand to hatch out. So.
And then when is it done? So this is a day 3 embryo.
So that's a day 3 embryo that's done when you're looking at those embryos. If you're doing PGS or if you're doing a transfer, those assisted hatching is recommended. And the question is, how do we do it? Well, there are different methods in the market that people do. There's mechanical, there's chemical.
So mechanical is with a needle. You hatch it with a needle.
You just hatch with the needle. The chemical, it's when you put an acid near the zona pellucida and it will dissolve the zona pellucida. Most IVF clinics in the U.S. they will use laser method. Where you go with the precise laser that hatches this rupture.
And you can see that right there.
So there's a little hole in the zona pellucida.
So is there ever a time that you would not hatch a day 3 embryo if you were doing PGS?
No, most of the practices we all hatch on day 3 for PGS.
Right.
Because we'll facilitate the herniation of the herniation of the trifectoderm, so when you can remove it.
Okay.
There's a question.
Yes.
What about PCOS patients? Should they have assisted hatching?
Doctor.
I'm
the doctor. Oh, yes. So as far as assisted hatching, yes, I don't discriminate against patients. It's not like I discriminate against the embryo and say no assisted hatching for you because you have PCOS. So I would say most of my patients still take the opportunity to do genetic testing, and so we would definitely do assisted hatching. So having PCOS wouldn't prevent you from benefiting from that.
That's a good question,
Yeah. Okay, so now it's the biopsy, and that sounds really, really scary, and I would want someone operating on my baby-to-be who has no tremor, and I noticed when you were doing all the stuff with your hands up here that you don't shake. So how
shaking,
important, no shaking. How important is it for you to be totally still and be really good at this procedure?
The benefit, because you're using micromanipulators, again, when I was playing video game, I was very good about my hand coordination.
Yeah.
So every moment and movement that you do with those joysticks, when you're controlling the holding or the biopsy needle, they are magnified by your movements. So you will hold this one hand with your holding pipette, and the other one you hold the herniation of the trifectoderm here.
Got it.
And then you push it a little bit, very gentle, because you don't want to
destroy the embryo. I mean,
more.
Could someone destroy? If you had the person who was answering the phone at the front desk, and all of a sudden you're like, "Hey, go pretend you know how to do embryology."
No, it takes a lot of years and a lot of manipulation for you to be able to.
So a lot of practice. So before they put you in charge of biopsying people's precious embryos,
you end up doing a lot of practice with research embryos.
Got it. Yeah, and that totally makes sense.
Yeah.
And so we talked about embryo biopsy, and now PGS. What does that stand for?
So PGS, it's the pre-implantation genetic testing, or I call it PGT, because the T is for the testing. And then we define in 2 categories: the screening, which is the PGS, and PGD, which is diagnosis. So the PGS, it's when you're screening for all the chromosomes in the embryo. And that's very important because you want to make sure that you have all the chromosomes from mom and from your dad. If you're missing or having too much chromosome in there, that could be a problem.
It could cause implantation failure, recurrent pregnancy loss.
And then the PGD, it's when you're diagnosing the embryo. Think about a prenatal for embryo. That's when you're doing a diagnosis for a specific gene. Of your, perhaps you have hemophilia in your family.
Or sickle cell.
Any genetic disorder that you want to eliminate from your family. And just keep in mind, we don't remove the disease from the embryo. We just check to see if the embryo has it. So from the pool that we have, then we check it. So we cannot edit embryo.
You can't create a designer baby. You can't make a brown-eyed baby blue-eyed, or a short baby tall.
No, there's not
you can't make me
such
blonde.
technology yet for that technology.
Yeah, but do you really think it's going to come?
Like PGS, we thought that was not there because now people are doing family balancing where they
gender selection,
and that's something that we never thought was going to happen. And I don't see that as a case. People are not choosing gender; they just want a healthy baby. That's all. Most of patients, they don't do gender selection. It's something that we're worried as an ethical part, but I don't see that nowadays.
No? Okay. So now that you've done the biopsy, now you have to freeze the embryo because you have to wait for the genetic testing results to come back. And there's so much stuff you read online from studies that frozen is better than fresh. So how do you actually freeze an embryo? What does that process involve?
Great question, and I'll explain in the very simple terms. Think about if you put a balloon or your embryo into a sugar solution drop.
Oh, that sounds nice.
And then your embryo, all the water will come out of this embryo, and then you dip the embryo into liquid nitrogen. So it's a very simple method where you just remove off the water of the embryo because the water causes ice crystal formation, and that will rupture the cell and damage.
Okay, that doesn't sound good. No. So you do it in a safe way.
We do it in a safe way.
You don't lose embryos from freezing.
No, we don't, because we can see the embryo when we load into the pipette.
Got it.
They're small, but we're looking under the microscope, and we can definitely see the embryo being set there. And it's a very sticky solution, so you can see the embryo stuck there. We dip into the nitrogen, and then it's frozen.
And then so how long would it take you to freeze like 5 embryos for somebody?
So each embryo takes about 3 minutes.
Okay.
So
total process for you, you're just like, I'm going to go freeze an embryo, and 3 minutes later that embryo's frozen?
So, yep, that pretty much 2 minutes plus 1, and you're done.
Wow.
And then
But I'm sure there's like a whole logging process too of
there's
patient
a lot
name
of
and labeling.
Yeah.
So it's not just 3 minutes.
Well, 3 to 5.
Okay, you're just fast.
No, it's just a very simple process.
Okay.
You log into the patient's record, you put that you froze that embryo, you print your labels,
Okay.
put the embryos, the labels on the stick because, and here's a lot of people, it's like, how don't you mess up the embryos? Or
Yeah,
put
I tell
different
them
embryos?
no,
Never.
never,
So
never, ever, ever.
We always have two people look at the ID of the patient before we even touch the freezing method, or we look at
the embryos to make sure that you're getting the right embryo.
Correct.
Got it.
So we always have
and same with sperm, same with eggs,
any process
everything.
in the lab. Every time that you touch gamete, you have another embryologist with you to make sure that you have the right patient.
Scenario: there's an earthquake in the Bay Area.
It's a great question.
What's going to happen with all those embryos in the tank?
So the good thing is that the embryo storage does not require energy. Doesn't require power. It's liquid nitrogen inside of this tank, as you can see here. So the only concern is to have the people who delivers the liquid nitrogen available to fill up those tanks.
And then how many times a week do they come to deliver liquid nitrogen?
Depending on the facility, depending on the size of the tank, there are many variables that you want to put in count. But a tank like this size behind me, and if you don't open daily, that can stay up fine with like 5 to 7 days.
Right. So is it your job, or do you guys rotate whose job it is to load and pour?
It's an automated filling. So this one is an older tank.
Okay.
The newer tanks nowadays, they have an automated filling, so it fills automatically. When it reaches the level, it stops, and it's connected to my phone, the alarm system.
No way.
So I will get notifications if the tank is low, if the incubator is alarming, anything that happens inside of the lab, I'm notified on my phone within seconds.
Wow. What about like a power outage? Would that hurt? That wouldn't hurt the embryos,
That
right?
would not hurt, but the incubators, the incubators are connected to the power source. So that's a lot of people ask those questions.
Yeah, but there are multiple levels of protections, like generators.
There's a generator, there's a UPS battery connected to the incubator. So there's many levels of security and protocols that it's in place for earthquake in that case. We're in the Bay Area, we're connected to all the fertility clinics. In case of emergency, I can transfer the embryos from my facility to another facility so they can take care of those babies, so those embryos. So it's a great method.
Okay, so now it's transfer day.
Day,
and so you're in charge. I mean, you have such a huge role in these people's lives, and they don't even know who you are. It's just nuts.
And you just appear in the room.
You just appear in the room, and then you disappear.
That's right.
For 2 minutes. And so what do you do with the embryo?
We are the babysitters that will load that embryo into the catheter and give to the physician for the transfer. So in the morning, we look at those embryos, we give the grading to the physicians, and between the physician and the patient, they'll discuss how many they'll be transferring. They select one, they'll let us know, and then place that into a transfer dish and be ready for that transfer time.
And so patients get a picture of their embryo.
Sometimes
they can see it on a screen.
We take a picture of those embryos. They can see the name of the patient or the name of the patient on the dish that I'm loading the embryo from. So everything has a chain of custody.
Nice. And then when you do a transfer, I call it the spark of life, where you push the end of the syringe and then you see this beautiful white flash. So what is that? I mean, the embryo is supposedly microscopic. So what is it that we're actually seeing?
So we're seeing the air bubble that reflects on ultrasound machine.
Got it.
So that's an assurement because in where I do the transfer, we put 2 little bubbles. So the embryo is between the 2 little bubbles, so you can see if the embryos got transferred.
So when you say bubbles, like you're blowing bubbles, or where are the bubbles?
It's an air bubble that's created manually on the catheter. I'll double check. We bring the catheter back, and sometimes, what are they doing back in the lab with my catheter? Well, we take the catheter back into the lab and make sure that because the embryo can get stuck sometimes to the tip of the catheter or it doesn't get loaded completely, then we can reload, put it back, and your chances are just like the same as
So basically, you can have a sticky embryo.
Yeah, just a sticky.
Got it. And it doesn't mean anything. You just load it back up and put it back.
Put it back in.
Got it. Okay, cool.
We've got a question
Yes.
from Facebook.
Yeah.
Is it easier to freeze embryos rather than eggs?
So embryos, it's the success. ASRM just removed the research criteria for egg freezing because think about us humans, we're big cells. We're a lot of cells. even freezing a whole body it's not possible right now.
Well, it is. It's expensive.
We can freeze it, but what's the success rate of thawing you?
0.
Yeah, we don't know yet. So same thing, the embryo, it's many, many cells. An egg is just one cell.
Right.
So it's just a bigger cell.
Right.
But
you're really good at it. I mean,
yeah, no,
it's like
the
if you
chances
froze
of
an
the egg
egg, the
is
survival
just
rate's
as
close
good,
to
yeah.
100%.
It's a survival
Right.
thing. Yeah, it's just great. And that's why Facebook, Google, and all those tech companies are encouraging their employees to freeze their eggs.
Right. So for me, when
And
I
who is
see...
the egg whisperer?
Right.
You want to say it, Dr. Amy?
No, so
I told my sisters, like, once you're ready to have a baby, but you want to freeze your eggs,
Right.
you come and talk to Dr. Amy.
But basically, when I have those conversations with patients, it really has to do with the FSH level, the AMH level, what the family size goals. Would you consider doing it within 5 years, meaning being a single mom by choice, or would you want to wait for a partner? So those are all the parts of the conversation that I have with patients before deciding on whether you create embryos up front or just freeze eggs. There's a lot involved for sure.
And even I had some cases where I've seen where a patient went through egg freezing by herself, and
Right.
then she created embryos as
Right.
well,
Right.
just to have an option plan A and plan B.
Absolutely, that's a great way of doing things too. So there's a lot of stuff trending out there right now. I've received an article. It's on my Facebook professional page from The Cut about how patients are potentially wasting embryos that could turn into healthy pregnancies, thinking that they're actually abnormal from PGS when they really could result in a healthy pregnancy. And I call that the murky crystal ball of IVF medicine. So I just wanted to talk a little bit about this word mosaicism and aneuploid and euploid, and what does that actually mean? And so does anyone actually transfer abnormal embryos, so embryos that have an abnormal chromosome?
I have not seen a case yet, but
Right.
some physicians are recommending their patients not to discard them just yet, because it's a new technology, so is fertility treatments. Since our first IVF baby, she was born 1970.
I don't know, but she's had a baby.
Yeah, she just had so it's a brand new technology still.
Right.
There's a lot to learn. So I believe that mosaicism and euploid and aneuploidy, it's still a field that we need to learn more. And
So if you're a patient of mine, I want you to talk to me about your concerns, but all my patients will get a report, and that genetic testing report will tell you which embryos are normal, which are not, and which are what we call mosaic. So depending on the chromosomes that are abnormal, there may be an opportunity to transfer, but it certainly doesn't mean that everyone should consider it and every embryo is a candidate for transfer. So this article has created lots of panic out there, and
Yes.
I can tell you it's just trending, and people are texting, emailing, Facebook messaging it to me, and I definitely saw it as soon as it came out.
yeah, I don't talk many with patients, but friends that ask my opinion, I always tell them just talk to their physician and they'll have the best answer for them
Right.
in that specific report.
Right. So I just wanted to say thank you, Salu, for being here tonight. I know we still have a lot of questions. So I know there are a couple of questions that we have emailed. One of the emailed questions that I got was, I'm 37 years old. I've been trying for 8 years. Is IVF good for me? And so what I would tell that person, because I don't know them, is that you really have to figure out what's going on, what's wrong, because you can't just go into IVF if, let's say, there's no sperm. So you wouldn't want to have that kind of surprise. So make sure you understand what your fertility diagnosis is before you do IVF, and do whatever you can to make things as good as possible. We used to say IVF is the most comprehensive fertility diagnostic test. It's only through IVF that you actually know what the egg and sperm will do together. But now we have fertility genetic tests that can guide you a little bit better before you do IVF, that can teach you more about embryo development, like looking at DNA fragmentation of sperm and epigenetic changes in sperm and fertility gene tests in women. So all of these things together can guide you, so you don't do an IVF cycle and say, oh my God, why did this happen? At least you go into it saying, well, I was expecting, or I knew that there was a chance that could happen. I'm really happy that there's one high quality embryo. Rather than looking at your cycle and be disappointed, be happy with what you have. So that's what I would tell the 37-year-old who's been trying for 8 years. Another question that I was asked was about brown, grainy eggs, and I think we
How
kind of
call
answered that.
Yeah, it's just the quality of the oocyte or the embryo.
And then another really important question that a lot of people are asking, because patients who've done IVF, let's say 2 or 3 years ago, they had embryos frozen, and now they're asking, is it safe for me to genetically test those embryos? And I have one more question that I was asked too after that. So is it like, if you have a set of 8 high quality frozen embryos on day 5, would you be comfortable as an embryologist thawing, biopsying, and refreezing them?
Yeah, we have done that quite a few times.
Yeah.
So that's a new process that we just thaw them, biopsy them, freeze them,
Right.
receive the testing, and then thaw the ones that are
For transfer.
euploid.
Yeah, that sounds like a lot to put a little embryo through, but
It's a very stressful for the embryo.
Right.
But it's done.
yeah. So when you say it's stressful, do you think it hurts the chances?
It's not the chances, but the thawing and freezing, that process, the manipulation, your embryo is outside of the best environment, which is the uterus. You put it again back in the lab. Not the lab is a bad environment, but optimal environment for your embryo, it's the uterus.
So you're saying just because there's human beings involved, sometimes things happen and there might be...
the patients sometimes request transfer from one embryo to another clinic.
Got it.
So the transportation too, like you want to minimize the chances
of something happening. But the chances of something really bad happening is pretty low.
It's pretty low.
Yeah.
It's very low, but there's a chance. And if that's your only embryos, that you have to think very much about it.
What about repeat biopsy? So we talked about mosaicism or abnormal embryos. Should you consider transferring them? What if an embryo has been biopsied once? Should you repeat the biopsy? And what's the safety on that?
So the recommendation from the reference lab, they recommend you not to rebiopsy the embryo. But again, some people do it.
Some people do it and they've had live births from it.
Yeah, no, definitely.
Yeah.
But it's just a recommendation.
Right. Okay, another question.
Can an egg be tested to see if it has a normal number of chromosomes?
Right. So I wish you could go to the grocery store, like go to Safeway and be like, I'm here for my eggs, and then just take a scanner and go, deep, right?
So, yes, you can...
Did you invent it? Is it coming?
No, test one egg for chromosomes.
Yes.
Yeah, pull a body biopsy.
But it's so hard to
but
do.
It's a technology that's not
available
as much, and also you want to...
And you can damage the egg by doing a
And then you don't know what's the other half, because the other half is the sperm, so you're only having certain information, and so no, it's not enough information.
I certainly wish that you could. That would make life easy for all the egg freezing patients out there.
Or even a method which is in development, that you can not biopsy, but you can remove the fluid of the blastocyst of your embryo and detect for abnormalities.
Right, so what you're saying is there are certain protein markers in the fluid that surround an embryo or egg, and depending on the amount of that marker, that could be a sign that the embryo is normal. Mm-hmm. Yeah, so where are we with that technology?
I would say 5 more years,
you think
5 to 10 more years.
Yeah. Hopefully it's
and then imagine that they have one report that they had artificial uterus. Imagine I'll be babysitting babies in the lab.
Yeah, sign me up.
Yeah, it'll be through science. All that we thought about all the science fiction movies, it's happening.
It's going to happen, and you'll be there, and I'll be here to talk about it. So, Slu, I really hope that you're going to come back again. Will you come back?
Yes, definitely. I'll be very happy to be back.
Okay, awesome. Well, catch Salu again. If you have any embryology questions, feel free to email us.
Yes.
If you ever have a fertility question, you can call in, email. You can catch this show or send it to a friend through our podcast as well. And thank you everyone for listening and watching. Be sure to subscribe to my YouTube channel and take a class, either the Tushy class, IVF class, or egg freezing class coming soon at eggwhispererschool.com. Bye everyone.
Thank you for listening and making the Egg Whisperer Show a part of your weekly routine. As always, you can read more about each episode at dramy.org under the blog tab. You can also find the Egg Whisperer Show on Spotify, Apple Podcasts, and Google Podcasts. While you're at dramy.org, you can find a link to the Egg Whisperer School, which houses Dr. Amy's online classes about fertility, and you can sign up for the Egg Whisperer newsletter to get bi-weekly updates so you can stay in the know about your fertility. You can also tune into the Egg Whisperer Show and watch Dr. Amy as she goes live on Facebook, Twitter, and YouTube each week on Wednesday at 7 p.m. Pacific Time. The Egg Whisperer podcast has new episodes each week on Thursday, and we hope to see you again next week. Have a great day.